Well, good evening, ladies and gentlemen, my dear professors and colleagues. First of all, I would like to make it loud and clear that I really do miss you all, and I hope that we can meet up again soon. Still, before we start, I have to salute the organizing committee for a job well done, pulling off such a professional virtual gathering. And I'm really both honored and excited to be among this prestigious scientific group. We're going to fly through a few pelvic cases, and unfortunately we only have half an hour, so we won't be able to cover all the pathologies, whether because of the multiple organs that we should be dealing with, or the fact that each organ has already multiple pathologies. So we're going just to fly through some of our everyday practice cases, and hopefully you would enjoy them. Let's jumpstart by this 32 years old female who already underwent delivery 2.5 years ago, and then she came in with persistent dysfunction and bleeding and menometrorrhagia for the last year. This is her transvaginal ultrasound. What do you spot? First of all, you have to center yourself, meaning you have to know where you are. So first look at the endometrial stripe. Once you find this echogenic line, then you are good to go. As you can see here, that the lesion is more or less related to it. It's well-defined, echogenic with cystic changes prolapsing into the cervical canal. So what's your differential? Could it be uterine or cervical? Well, I think most of us, including myself, would say it's uterine in origin. Okay, is it endometrial or myometrial? Again, I think most of us would say that it's endometrial in origin. What's the most common lesion that we might face? Well, benign hyperplasia of a polypoid type, of course. It can be cancerous, though she's a younger age group, but still, unfortunately, we do identify nowadays cancers in a younger age group. Or it could be something related to her prior pregnancy. Still, humor me and put the myometrial origin of the lesion in the background of your mind, and you will know just why in just a second. This is her MRI, the sagittal T2 weighted image, and this is the coronal oblique, meaning that I've cut perpendicular to the uterine body axis, and I can see clearly the uterine cavity as a triangular with the base up. So here's our lesion, well defined, with cystic changes. But what about its pedicle? We do spot myometrial tissue within the pedicle of this lesion. And on the axial images, we can see the lesion very well defined, prolapsing into the cervix, playing it with no infiltration whatsoever. And the cystic component does show high protein content. Still, there is no blooming on the SWI. What you see here as signal voids are merely the vessels insinuating within the rest of the parenchyma. So let's put our ducks in a row. We have a lesion that's originating from the myometrium, well-defined, prolapsing into the endometrial cavity with no frank bleeding. So this is actually prolapsing degenerate type 0 fibroid. Okay. What's the type 0 stands for? Well, we are all familiar with the major categorization of fibroids into submucosal, subserosal, and interstitial. The numerical classification is just a subclassification of the main in order to try and diffuse any misconceptions. So that when I say I have a type 0 fibroid, this means I have a pedunculated submucosal lesion. But when I say I have a type 7 fibroid, this means that I'm going to have a pedunculated, this time subserosal lesion. Okay. So look for the origin, it will narrow down your differential. The signal intensity is very crucial since we don't find any blood, frank blood within this lesion. We didn't term it a focal adenomyoma, for example, which might again be spotted easily on such cases. Vascularity does appear well on the SWI, and not only cancers or hyperplasia do present by bleeding. Again, a case of bleeding, but this time in a postmenopausal female, and this is her transvaginal ultrasound showing diffuse, thickened myometrium with cystic changes. We're going to jump directly to the endometrial differential, putting again hyperplasia into mind, maybe carcinoma more due to her older age, but you have to be very careful not to miss a very important question, which is she on hormone replacement therapy, whether for osteoporosis or maybe she's a breast cancer patient, because exogenous hormones do give you the same effect. And this is her MRI. We can see the involuted uterus clearly with thick endometrium harboring an iso-intense signal with few bright foci of cystic changes. Still, the endometrial myometrial interface is totally intact all through the multiplanars. So is it something benign or malignant? And here comes the role of diffusion. Diffusion nowadays is very pivotal in the routine MRI of the pelvic lesions. But please don't be alarmed if you find that the endometrium appears a little bit bright on the DWI, because the normal endometrium does appear bright. Look directly at the ADC. Is it dark? Is it restricted? Or is it just bright? If it's still just bright, this means that it's not restricted, and better yet, not only use the qualitative methodology, but use the quantitative and measure. And as long as it's not restricted, then I'm dealing with a diffuse benign hyperplasia. So again, hyperplasia is associated with bleeding, not only cancer. To spot the activity of the lesion and scrutinize suspicious from suspicious, use the DWI. Bear in mind that some cases of ovarian cancer, or let's say ovarian stromal tumors, not only the suspicious type might be hormone secreting. And this means that they would lead to endometrial hyperplasia, and they might even present earlier indirectly by the spotting per vagina. And again, don't forget to ask about the hormone replacement therapy. Again, a postmenopausal bleeding case, but this time we have the uterine body and the cervix being splayed or filled up by this sizable isoechoic lesion with few hypoechogenistics, but it's isoechoic to the surrounding myometrium. So what's your differential? Body or cervix? Let's go for cervix. Could it be cervicitis? Actually, not that much. Cervicitis should lead to diffuse bulkiness of the cervical clog. Could it be cancerous? Yeah, polypoid type maybe, or just a polypoid hyperplasia. But still, don't forget a very important point. The lesion was isoechoic, meaning that I have to put the myoma or the fibroid in my differential. Could it be a uterine body? Might be, but since it's isoechoic, we won't go for the endometrium this time. We're going to go for the myometrium, and it might be just a prolapsing leiomyoma or a leiomyosarcoma. That's why she underwent MRI. And as you can see here, the involuted uterus clearly identifiable with a barely identifiable endometrial stripe due to the resting postmenopausal status. And this is the cervix. We can clearly differentiate the cervix from the body by the markedly hypointense cervical stroma. And when we went a little bit parasagittal, we find that we have a well-defined isointense lesion to the myometrium, splaying the endometrial, the cervical cavity. And on the multiplanar, we found that it's actually pedicle, so it's a prolapsing myometrial-based lesion, a fibroid. But is it from the cervix or is it from the body? Yeah, please, if you look here carefully, you would find that the pedicle is above the cervical tissue. And this is it on the sagittal view, is directly above the cervico-ethmoid junction. So what am I dealing with? First of all, I'm dealing with a fibroma, but actually, again, prolapsing from the uterus. And once you have a fibroid, don't be alarmed if you find that it looks dark on the ADC map. Look at the DWI, you'll find that it's again dark. So dark means that it's a blackout effect, because fibroids are made mainly of fibrous tissue. So they are devoid of water. You won't find any vascularity, any water diffusibility with them, and that's why it would appear as if restricted. And when you carefully measure, you might find that it's of a borderline restriction, not a true restriction that much. So we are dealing again with a prolapsing type 0, and this time you might call it a pseudocervical fibroid. Why is it important to identify if it's of a cervical origin or a uterine body origin? Because the management will totally change. If I have only a type 0 fibroid, the clinician might go in with a hysteroscope, twist the pedicle and take it out. While the cervical fibroids, as you can see here, they are not plotted on the scheme because they are, first of all, a little bit rare. And secondly, if they are found, they would be labeled type 8, the same as in broad ligament or parasitic fibroids. and they are difficult in their management. We might even end up by hysterectomy. So again, look for the origin, look at the signal of the lesion. Fibroids do appear dark on the ADC map, don't get alarmed, and they are again associated with bleeding. Hopefully our last case with postmenopausal bleeding so that you don't get bored with the same clinical scenario. Again, showing a thick endometrial stripe, more or less of homogeneous echogenicity as seen here on the axial image. So you go directly for the same differential of endometrial lesions, and this is her MRI. As you can see here that the endometrial cavity is ballooned by an iso-intense, maybe a little bit hypo-intense lesion, totally homogeneous. Still we have the endometrial myometrial interface totally intact, though it's ballooning and stretching the surrounding myometrium. There is no evidence of frank infiltration. So should we label it as a benign lesion, though it appears a bit more cellular than normal? Well, we cannot say if it's benign or malignant unless we look up the diffusion-weighted imaging. And as you can see here, it's bright, yes, on the DWI, but on the other hand, it appears dark on the ADC map. And when we measured, we did find true diffusion restriction. So once you have a suspicious lesion, go back and look for the rest of the pelvis. Look very carefully for the lymph nodes and the adnexal, because this might upstage your lesion. And the lymph nodes would appear normally, the resting or the reactive nodes would appear normally bright on the T2 with a preserved fatty hilum on the T1. Unfortunately, even reactive nodes might give you some sort of restricted diffusion. They might appear bright on the DWI or even dark on the ADC map. So first of all, measure. If it's not true darkness, if it's not true restriction, then you are good to go. Even if it's a borderline restriction or that you find it less than 1, compare it with the number of the index lesion. If it's of the same number, then this goes more with restricted diffusion or infiltration, especially if you have also morphological changes. But if you don't, then they are still equivocal. So this case was actually an endometrial carcinoma. The signal is crucial in this area. Once you get the hang of it, you would lean towards the fact that carcinomas do appear darker than mere hyperplasia due to the cellular compactability. And in order to scrutinize the activity of the lesion, just look at the DWI and measure on the ADC map. Hyperplasia is not restricted. And lastly, don't forget to look at the adnexal and lymph nodes, since it might upstage your lesion, even if it's totally non-invading of the myometrium, and it should be labeled as a 1A according to the FIGO staging. Just one pelvic lymph nodes would upstage it to 3C1. Okay. Now let's shift gears from the bleeding scenario and go for the pelvic pain. This is a known female with fibroids, and she came in recently with marked pelvic pain and fullness and the sensation that her abdomen is getting bigger and bigger. And this is her ultrasound showing a sizable heterogeneous lesion with cystic changes and mottled echogenicity, more or less an ugly looking lesion, if you might say. So could it be endometrial or could it be myometrial? Well, we have to put both possibilities. If it's endometrial, it's going to be cancerous. If it's myometrial, can be either just a degenerated fibroid, but with marked degeneration giving you this heterogeneous appearance, or it might be, better yet, a leiomyosarcoma. And this is her MRI. As you can see here, this is the cervix and this is the uterine body, and there's a sizable fleshy-like lesion, more or less infiltrating the uterine body. And as we can see here clearly on the coronal oblique, that there is disruption of the myometrial mantle and there is an exophytic component of the lesion. So how should we deal with this sizable lesion? We have to identify the endometrial stripe. So if you can see the endometrial stripe clearly, this means that you are not dealing with a primary endometrial lesion. And this is in fact is a primary mesenchymal lesion with an aggressive behavior as seen here on the axial image with irregular outline, lobated outline, and central cystic changes. But again, this might be just degeneration. So what should we do? We would go for the DWI. Normally, fibroids would appear dark on the DWI as well as the ADC. If I have a hyperintensity on the DWI, I have to look directly for the ADC, because degenerated fibroids, edematous fibroids, means that I'm going to have water in between this fibrous tissue, would appear bright. So if the ADC map shows no diffusion restriction, this means that I might be just dealing with a degenerated part of the lesion. But if it does show evident diffusion restriction, despite being hyper on the DWI, then this means that I'm dealing with a suspicious lesion. So the sizable lesion was actually, in fact, a suspicious one, but we have another fibroid that's lower down, as seen here on the axial view. Fibroids do appear T2 hypo, but before labeling it as non-degenerated, look at it across the rest of the sequence, because they should appear isointense to the surrounding myometrium. So if they appear hypointense to the surrounding myometrium on the T1 weighted image, better identified here on the fast suppressed image, with element of blooming on the SWI and markedly jet black on the DWI and ADC map, this means that I'm dealing with a markedly sclerotic fibroid. So this is not just mere fibrous tissue. This is sclerosis or hyalinization, and this is how a hyaline degeneration would look like. And if you are used to give contrast in your institution, you would find that they don't pick up contrast whatsoever. And these are actually the types of fibroids that would present later on by dystrophic calcification. So our case did show a fibroid uterus, with one of them being malignant and the other just showing hyaline degeneration. So remember, in order to tackle a sizable lesion, look for the endometrium, as well as the rate of growth. If you have a known patient with fibroid and then she comes in with doubling or tripling the size of the fibroid, and in order to clearly pick up if it's a suspicious leiomyomatous lesion or just a degenerated fibroid, look at its activity on the DWI. And these are other examples dealing with sizable lesions. As you can see here, we have a pelvic lesion invading even the urinary bladder. Is it cervical in origin or is it just endometrium? Well, we have an intact endometrial interface, so this means is this cervical. This is another case, again, showing a sizable pelvic abdominal lesion. But where's the endometrium? Actually, here's the endometrium, and there is disruption of the endometrial-myometrial interface, and the lesion is sizably exophytic from it. And this is primary endometrial with diffuse infiltration into the surrounding tissue. Now let's shift gears from the uterine and cervical lesions to the adnexal. This is a 19 years old young female with suspected complex right adnexal lesion. As you can see here, we have a cyst with turbid content, and we have this echogenic focus. So what's your differential? Since she's a little bit young, we would go directly for a Kitansky nodule, maybe of a dermoid, or maybe a blood clot, either in a functional cyst or part of endometriosis. And though she's 19 years old, bear in mind that once she gets her menstruation, maybe at 13 or 14 years of age, she might be susceptible to get endometriosis. Lastly, we would put soft tissue component, but not that much, maybe because of her age, but still we do spot juvenile ovarian carcinomas, unfortunately. And this is her MRI. As you can see here, we have this right adnexal lesion with T2 shading and other smaller lesions showing the same signal. On T1, they are hyperintense, not milling on fat suppression sequence, meaning that I'm dealing with high protein content or blood content. And the focus that we've seen on the ultrasound does appear hypointense on the T2 or a T2 shading again. And on the T1, it's hyperintense and it did not mill. So this negates the possibility of fat component. And on the DWI, it's jet black and there is blooming on SWI. So what's your differential? this was actually a blood clot within an cystic endometriosis as part of a diffuse endometriosis process. Yeah, I did not show you the Doppler of this case, but it did not show Doppler vascularity. Still, the absence of Doppler vascularity does not negate that this echogenic focus might be some sort of soft tissue component. And when you try and characterize a lesion by MRI, look across all sequences. Not only the T2, you have the T2, the T1, the fat suppressed sequence is very crucial to identify high protein content from fat. Then you have the SWI for the blood content, of course, as well as the diffusion. This is again another case with the suspected, this time left adnexal cystic lesion. And here we have polypoid-like echogenic structure within the cyst with positive vascularity. And when we shifted the probe a little bit, we found that the low-level echo fluid does have another echogenic layer on top of it. So what's your differential? Could it be a soft tissue component due to the vascularity? Or could it be just a Rokitansky dune? A blood clot, no, maybe not so much because of its shape. And this is her MRI, T2, T1 fast suppression. And this here mirrors the polypoid structure that we've seen on the ultrasound. And it appears to be bright on T1 with nilling on T1 fat suppressed imaging. This means that it's fat containing. And again, the layered echogenic fluid proved to be fat. And since the density of fat is higher, it would float on top of the rest of the fluid. What you see here as bright signal on the DWI is actually a pathognomonic for fat, which is called the chemical shift artifact due to the high interface between the two structures. And bear in mind that once you see blooming on the SWI, don't jump to the conclusion that it's blood. No, fat does give you blooming, the same as blood. So don't just look at the SWI. If you have just looked at the SWI and you found blooming, you would label it as blood. No, look at the basic sequences, the conventional sequences, the T1 fat sat, the T2. And this would give you the clue that you are dealing actually with fat that's maybe confirmed here by the blooming on the SWI. When we went a little bit down, we found that we have another lesion on the right side, this time showing T2 shading of a clot, hyperintensity on T1, not milling on fat suppression. This means that it's not fat and there is blooming of blood this time on the SWI. And this is her coronal and sagittal view. And if you look at the sagittal view, you would find that the fat layering would be floating on top of the fluid, as we said, while the blood layering would be layering or sedimenting down. Okay, so though we had positive Doppler vascularity, this was not suspicious. This was just the mere normal vascularity within the septi. And again, MRI did show you the final diagnosis according to the signal of the tissue you are dealing with. So this was, in fact, a teratoma associated with a hemorrhagic cyst, whether functional or maybe a cystic endometriosis. Our last case is a 37 years old female with persistent post-abortion bleeding. And this is her ultrasound showing this echogenic lesion that did show marked vascularity on Doppler analysis. So would you narrow down your differential to a pregnancy or non-pregnancy related lesion? I do believe that since she started complaining after pregnancy or after abortion, let's say, it would be pregnancy related. The next question is, did she undergo DNC or not? If she had underwent DNC, then acquired AVM would be your prime consideration. But our case was managed by medication. So she did not go for DNC. So what's your next differential? Might be just retained products of conception. They do show positive vascularity. Or it might be a gestation trophoblastic disease, either a complete hydatiform mole or a choriocarcinoma if we find metastasis. And there's a rare entity of the gestation trophoblastic disease, but we have to mention, which is the placental-side trophoblastic disease, and I'm going to tell you why later on. And this is her MRI. We see the uterine cavity ballooned by this heterogeneous lesion with the multiple signal voids. Still, we have the intact endometrial myometrial interface with no increased vascularity within. And again, on the T1 non-fast suppressed image and the SWI, it confirms the blood and the vascularity. And on the diffusion weighted imaging, there is no brightness, there is no restriction as measured here. So this should go directly with mere simple retained probability of conception. What's more confirming to this would be the non-presence of cervical lutein cysts. Because if I have a gestation trophoblastic tumor of a vesicular mole or a choriocarcinoma, they are usually associated with high beta HCG, and high beta HCG would lead to increase in the follicular size of both ovaries. As you can see here, we have a normal sized right ovary, and the left just shows the corpus luteum. But let me tell you that the other way, the other scenario, that we did in fact have a suspicious diffusion restriction, that it was in fact a suspicious gestation trophoblastic disease, still we had normal looking ovaries. This would not negate the presence of a gestation trophoblastic disease. It would negate its subtype as being vesicular maybe or choriocarcinoma. However, placental tumor site that is not associated with high beta HCG. And that's why sometimes it's even difficult to identify it on imaging, and it's only identified on histopathology. So bear in mind that if you have a suspicious pregnancy-related lesion, don't just dismiss it because you don't find a high beta HCG within the lab or a thick lutein cyst within the ovary, okay? So this was straight through a retained probability of conception. So I think this is just a wrap up to what we have just said. Look for the history of DNC, the beta HCG. Bear in mind that Doppler is not specific in these cases. And if you find a suspicious lesion on the DWI, do an MRI of the brain, do a CT chest to look for distant metastasis, which might upgrade it from just a vesicular mole to a choriocarcinoma. And lastly, you are clinicians. You have to know the clinical scenario of your case very well, link it with the lab before going directly to the imaging. And your first line would always still be the ultrasound, followed by the MRI for better narrowing down of your differential, and maybe even characterizing and staging of the lesion, if it's a malignant lesion, or scrutinizing it from the different malignant mimickers. And lastly, I just want to salute every healthcare worker on the front lines. You are really my superheroes. Thank you.